All right. Hello, everyone. My name is Daniel PK. I'm here with StudyRare, and today we'll be trialing a new format, audio and video of the newsletter. I'm really excited to try this and also to hear your feedback on whether this is a format that works for you. So please feel free to reach out, comment in the newsletter post, or on YouTube to let me know how you like this format. Before I get started with the questions, which we'll kind of just read through the newsletter post, read through the questions, the answers, and the explanation. Before I do that, I'd like to first just congratulate everyone who's taken the ABMGG or ABGC exam this month. Again, congratulations, a big milestone. Part of what I'm trying to do at StudyRare is to improve the process for exam preparation, particularly for genetics exams. And so I'd love to meet with you if you're so inclined and just hear about your board preparation experience and how we could make this better. So I have some availability over the next 2 weeks. I've included a link here where you can essentially sign up for some times if you'd like over these next 2 weeks. So definitely look forward, hopefully, to meeting you and speaking with you at some point soon. And with that, let's go ahead and read the first question. So question 56, a 4-year-old boy with global developmental delay presents for an evaluation. He has a G-tube that he relies on for feeding, and his weight and length are normal. The physical exam shows no speech, hypotonia, hyperpigmented streaks on the back and abdomen, and coarse facial features. A karyotype from a buccal swab shows the following karyotype, which you can see there. You can also see a picture of that karyotype down below. So what is the most likely diagnosis? Is it incontinentia pigmenti, hypomelanosis of Ito, Pallister-Killian syndrome, or focal dermal hypoplasia? I encourage you to take a second, pause the video, and think about what the right answer might be. Okay, so the correct answer in this case is Pallister-Killian syndrome. So that's choice C. This individual, this child, has a couple features that really point towards that diagnosis: the developmental delays, the hyperpigmented streaks in particular point towards and are evidence for mosaicism, which is a characteristic, a hallmark of Pallister-Killian syndrome, as well as the coarsening of facial features can be seen in this particular condition. The karyotype here is showing an extra chromosome 12p, in particular tetrasomy 12p. So there's actually 2 chromosome 12p's linked at the centromere here, and that's what this arrow is suggesting, and that is diagnostic of Pallister-Killian syndrome. So some of these other answer choices we'll talk about below, but essentially they can also, all of these can present with some type of skin pigmentation abnormality, be it hyper or hypopigmentation. And so these are good disorders to have in mind in terms of a differential diagnosis when you're seeing an individual with developmental delays and skin abnormalities, particularly streaks or whorls, which we'll talk about in a second. Okay. Now, question 57 states the molecular basis of the disorder in the previous question is associated with the presence of which of the following? So is it polyploidy, an isochromosome, pericentric inversion, ring chromosome, or Robertsonian translocation? Take a second just to think about what the right answer might be. Okay, so in this case, the correct answer is an isochromosome, and we'll talk about exactly what an isochromosome is. But essentially, we saw a picture of it in the previous question. So isochromosome referring, so iso means equal or the same. And so we actually have a chromosome that's made up of two identical arms, in this case, the P arm of chromosome 12. And that's essentially what we see here in this karyotype. Some of these other answer choices can be seen in other disorders, and we'll talk about some of those disorders later on in this post. Okay. All right, so getting into the explanation. So this first paragraph describes Pallister-Killian syndrome, which we've already seen in this patient. Patients have hypotonia, developmental delays, these very characteristic hyperpigmented, could also be hypopigmented streaks on the trunk. And we see this individual here, a very nice illustration of those hyperpigmented streaks in a linear, or in some cases, a whorled pattern. There's also some hypopigmentation on the one side of his forehead as well. So patients with Pallister-Killian can typically have also seizures, coarsened facies, and delays. So patients can be pretty severely affected. However, there's a great deal of variability, and a lot of that depends on how much mosaicism for this tetrasomy 12p there is in the body. So just a little way to remember Pallister-Killian and the associated with the pigmented streaks. So you can just kind of see the association between the spelling of the word Pallister-Killian and pigmented streaks. Just note that similarity, and that should help you remember that for exams and for your clinics. So the next part of this explanation is talking about an isochromosome. And so what is an isochromosome? We talked about it already, where you have two chromosome arms that are essentially identical and that are linked together at the centromere. And so how does an isochromosome arise in the first place? So typically when chromosomes undergo division during mitosis or meiosis, the centromere undergoes what's called longitudinal separation. And that's illustrated here on the left half of this figure. So essentially the centromere divides, in this case, longitudinally. The two halves of genetic material, the two sister chromatids, separate into separate cells, and we end up getting a balanced set of daughter cells with a balanced set of genetic material. Now, when the centromere divides in a transverse fashion, so essentially 90 degrees relative to the longitudinal separation, we can end up getting essentially both of the P arms going into one cell and both of the Q arms going into the other cell. And that's not what's typical. That's not necessarily what we want. But this is a way by which isochromosomes can form, and particularly in this particular condition with Pallister-Killian syndrome. So good to keep in mind that it's the axis of the division of the centromere that can be a mechanism by which isochromosomes arise. Okay, so we're going to walk through all of these different terms and what they mean. So I know that a lot of times the nomenclature can be a little bit foreign or abstract, but I'm hoping to break it down for you here, okay? So first, we start with the letters MOS. So this refers to mosaic. Those are the first three letters in mosaic. And what this means is that, when a cell is mosaic, or when a population of cells is mosaic, it means that there's two or more populations of cells, the one that contain one karyotype and another subset of cells that contain a different karyotype, right? That's all that means. So this next part here is essentially going to be describing the karyotype for that first population of cells, right? So in this case, 47XY. So typically we have 46 chromosomes. So we know right off the bat that we have an extra chromosome. We have a male karyotype, so X and a Y. And then we have this plus sign, which indicates the presence of an extra chromosome. followed by the letter I, which is stands for isochromosome. And so that's important to keep in mind as well, because what follows is the description of that isochromosome. So in this case, in parentheses, next we have the number 12. And so that is indicating that we're looking at chromosome 12, followed by P10. And so that's indicating the essentially the centromere. So this isochromosome involves the P arm of chromosome 12, starting from the centromere and going all the way out to the end, the P terminal end of the chromosome. And so this last little bit here, 21, refers to the fact that there were 21 cells that were identified as having this particular karyotype. And we see 9 cells that were identified as having a typical 46XY male karyotype. And this / delineates marks the difference between these two sets of karyotypes. So that is how we interpret this mosaic karyotype. Okay, we have a little more details about how to calculate percent mosaicism, which can be helpful. And in general, patients who have a greater percentage of mosaicism for the abnormal karyotype tend to be worse off clinically. Okay. Now, we can talk a little bit about the incorrect answer choices. And I always encourage students, or really anyone, when they're learning for multiple choice questions, to really also look at not just the correct, but also the incorrect answer choices, because you can learn just as much, if not more, from these questions, from these incorrect answer choices. So essentially, the differentiating features are discussed here. So incontinentia pigmenti, or IP, X-linked dominant disorder, it's male lethal, and it can certainly present with skin changes. However, the key with IP is that the skin changes evolve over time. And so neonates and infants will start off typically with a blistering rash. And that's something that can be confused a lot of times, or that can confuse clinicians with something like herpes simplex virus. And so something to keep in mind as far as your differential diagnosis, if you're thinking about herpes, is incontinentia pigmenti. This rash will then evolve over the course of several months into a wart-like rash, followed by hyperpigmented streaks, and then finally linear hypopigmentation. So it's a sequence of different skin changes, and that's really characteristic of IP. So, and contrast that to Pallister-Killian, where the pigmentary changes are usually present right from birth, and they typically don't change a whole lot, right? So also keep in mind that with IP, you're not going to see this show up on a karyotype. So while patients have deletions, a lot of times you have this very common 11 kilobase deletion involving the IKB-KG gene. Oftentimes, this is too small, or I would say this is always too small to be seen on a karyotype. So karyotype, the limit of detection might be a few megabases. This is on the kilobase scale. So forget about it. You're not going to see this on a karyotype. Here's a few ways just to remember some of the high yield associations with incontinentia pigmenti. And remember that time course is really important to keep in mind when you're thinking about this disorder. Okay. Next is hypomelanosis of Ito, or HI. So this really is not actually a genetic disease, a monogenic disease. It's really more of a sign of somatic mosaicism that can be caused by a variety of different genetic etiologies. And so usually, it was initially described as having streaky or whorled hypopigmentation, and so lack of pigment, and contrast that with the hyperpigmentation that we saw in our patient in this case. Some of the key features of HI are mosaicism. That really is perhaps the key feature of this condition. However, when we see, in contrast, we can contrast this with Pallister-Killian, the sense that we do have mosaicism as well, but we also have developmental delays, the hyperpigmentation, as well as the isochromosome 12p that's diagnostic for Pallister-Killian. So again, this illustrates a general principle about mosaicism, and particularly when you see it in the skin as presenting as some of these streaks or whorls. You really want to be thinking about some kind of mosaicism if you see that in the clinic or on an exam. Okay. The last condition we have here is focal dermal hypoplasia, also an X-linked dominant condition, as with incontinentia pigmenti. So in this case, we're going to have multiple congenital anomalies in addition to some of these hyper and or hypopigmented streaks. So you're going to have multiple skin anomalies, so skin aplasia, hypoplastic nails. Patients can also have limb anomalies, so they can have syndactyly, oligodactyly. They can have facial asymmetry and a variety of ocular abnormalities. So keep in mind that this condition arises from pathogenic variants in the PORCN gene, which encodes a porcupine O-acetyltransferase. So again, not associated with findings that you would see on a karyotype, but good to keep in mind when you're thinking about a child or an infant with skin pigmentation abnormalities. Okay. Now, when we talk about question 57, some of those incorrect answer choices, polyploidy. So usually the human genome is diploid, meaning that there's 2 copies of each chromosome. Polyploidy is when we have 3 or more copies of a genome. And so what's interesting is that there are some cells in our body, like liver cells, that can be a certain population or percentage of which are polyploid, in fact, and that's normal. However, when you have polyploidy affecting the entire person or the entire fetus, that's not good, and that's going to result in a miscarriage. So the most common form of polyploidy that we see in fetuses is triploidy. And so you can have a 69XXY or 69XXX karyotype. And again, this is not viable and will result in a miscarriage. Pericentric inversions can arise when a segment of the chromosome essentially inverts, and when that segment includes the centromere. So contrast that with a paracentric inversion, where you have a segment that inverts, but it does not involve the centromere. So one example of a pericentric inversion is the inversion 8. So this is a inversion that involves the centromere of chromosome 8, and individuals who are carriers are usually asymptomatic, as is the case with most inversions, but they can be at increased risk for having a child with recombinant 8 syndrome. And there's a video about recombinant 8 syndrome, which I encourage you to check out. And this syndrome is pretty severe and can present with multiple congenital anomalies. Individuals will have a deletion and duplication of the 8th chromosome. So that's also a clue as to the presence of recombinant 8 syndrome. Okay. Ring chromosomes can occur and can be a cause of a variety of different genetic disorders. Essentially, when you have a ring chromosome on a karyotype, you're going to see the notation R. So the letter, lowercase letter R to indicate the ring. And one example of a genetic syndrome that's associated with a ring chromosome is ring chromosome 20 syndrome. And there's a link if you'd like to learn more about this syndrome here as well. Robertsonian translocations involve 2 acrocentric chromosomes. So again, these are the chromosomes that have very short P arms. And individuals with Robertsonian translocations are typically asymptomatic. However, they are at risk for recurrent miscarriages and or having a child with an autosomal trisomy like trisomy 13 or 21 if one of those chromosomes is involved. So overall, the objective from this particular newsletter post is to recognize Pallister-Killian syndrome as an entity that is mosaic and that's associated with tetrasomy 12p. Should also know that patients with Pallister-Killian have developmental delays, hypotonia, and pigmented skin streaks that are really highlighting the fact that there's mosaicism in this particular condition. So you can make the diagnosis with a karyotype. And in general, whenever you see whorls or streaks on the skin, whether it's hypo or hyperpigmented, you really want to think about whether that patient could have some element of somatic mosaicism. So here are some links to the exam blueprints, as well as some references if you'd like to take a look. And please feel free to forward this newsletter to anyone you think might be interested, particularly new or incoming genetics residents or genetic counseling students. And as always, I'm open to your feedback on this newsletter as well as this first video. So please feel free to reach out with anything, and we'll hope to see you next week.